Hey, ardent fans and constructive critics, I presume your dear and near are in fine fettle in 2021 too, in spite of the second corona wave all around the globe. It is social activist and good-hearted preacher Professor S. Suresh back with absolute delight from a 130-second video on unbeloved publication on YouTube today, 22nd April 2021, Thursday. The topic for today is robo-assisted surgery, shortly ARAS, also known as minimally invasive surgery, comparison to conventional manual surgery. Robotic surgery are types of surgical procedures that are done using robotic systems. Robotically assisted surgery was developed to try to overcome the limitations of pre-existing minimally invasive surgical procedures and to enhance the capabilities of surgeons performing open surgery. In the case of robotically assisted minimally invasive surgery, instead of directly moving the instruments, the surgeon uses one of the two methods to administer the instrument. These include using a direct telemanipulator or through computer control. A telemanipulator is a remote manipulator that allows the surgeon to perform the normal movements associated with the surgery. The robotic arms carry out these movements using end effectors and manipulators to perform the actual surgery. That's why it is called as remote surgery also. In computer control systems, the surgeon uses a computer to control the robotic arms and its end effectors. Though these systems can still use telemanipulators for the input. One advantage of using the computerized method is that the surgeon does not have to be present, leading to the possibility for remote surgery. Robotic surgery has been criticized for its expense, while the average cost in 2007 ranging from US dollars 5,607 to US dollars 45,914 per patient per surgery. This technique has not been approached for cancer surgery as of 2019, as the safety and usefulness is unclear. First robot to assist in surgery was the Arthrobot, which was developed and used for the first time in Vancouver, Canada in 1985. This robot assisted in being able to manipulate and position the patient's leg on voice command. Intimately involved were biomedical engineer James McEwen, Jeff Machinlech, a UBC engineering physics graduate, and Dr. Brian Day, as well as team of engineering students. The robot was used in the orthopedic surgical procedure on 12th March 1984 the UBC hospital in Vancouver. Over 60 arthroscopic surgical procedures were performed in the first 12 months. Other related robotic devices developed at the same time included a surgical scrub nurse robot, which handled operating instruments on voice command, and a medical laboratory robotica. In 1985, a robot, the Unimation Puma 200, was used to orient a needle for the brain biopsy while under CT guidance, computerized tomography guidance, during a neurological procedure. In the late 1980s, the Imperial College in London developed robot, which was then used to perform prosthetic surgery. The advantages of this robot were its small size, accuracy, and lack of fatigue for the surgeon. In 1992, the robot doc was introduced and revolutionized orthopedic surgery by being able to assist with hip replacement surgeries. The later was the first surgical robot that was approved by the FDA, Food and Drug Administration in USA in 2008. The robot doc from integrated surgical systems working closely with IBM could mill out precise fittings in the femur for hip replacement. The purpose of this robot doc was to replace the previous method of carving out femur for an implant. The use of a mallet and broach RAS. Further development of robotic systems was carried out by SRI International in Intuitive Surgical with the introduction of the Da Vinci surgical system and computer motion with the AESOP, the ZEUS robotic surgical system. Da Vinci is so popular for the past 20 years, 2 decades. The first robotic surgery took place at the Ohio State University Medical Center in Columbus, Ohio, USA, under the direction of Robert E. Mishler. AESOP was a breakthrough in robotic surgery when introduced in 1994, as it was the first laparoscopic camera holder to be approved by the FDA. NASA, USA, initially funded the company that produces AESOP is of computer motion due to its goal to create a robotic arm that can be used in space, but this project ended up becoming a camera using laparoscopic procedures. Voice control was added in 1996 with the use of 2000, and 7 degrees of freedom to mimic a human hand was added in 1998 with the use of 3000. ZS was introduced commercially in 1998 and was started the idea of telerobotics or telepresence surgery where the surgeon is at a distance from the robot on a console and operates on the patient. Examples of using ZS include a fallopian tube reconnection in July 1998, a beating heart coronary artery bypass graft in October 1998, and the Lindbergh operation, which was a cholecystectomy performed remotely in September 2001. In 2003, ZS made its most prominent mark in cardiac surgery after successful harvesting the left internal mammary arteries in 19 patients, all of which had very successful clinical outcomes. The original telesurgery robotic system that the Da Vinci was based on was developed at Stanford Research Institute International Menlo Park, USA, with grant support from DARPA, and NASA, USA. A demonstration of an open bowel anastomosis was given to the Association of Military Surgeons of the USA. Although the telesurgical robot was originally intended to facilitate remotely perform surgery in the battlefield and other remote environments, it turned out to be more useful for minimally invasive on-site surgery. The patents for the early prototype are sold to Intuitive Surgical in Mountain View, California, USA. The Da Vinci senses the surgeon's hand movements and translates them electronically into scaled-down micro movements to manipulate the tiny proprietary instruments. It also detects and filters out any tremors in the surgeon's hand movements so that they are not duplicated robotically. The camera used in the system provides a true stereoscopic picture transmitted to a surgeon's console. Compared to the ZS, the Da Vinci robot is attached to broadcast to the surgical table and can imitate the human wrist. In 2000, the Da Vinci obtained FDA approval for general laparoscopic procedures and became the first operative surgical robot in the US. Examples of using the Da Vinci system include the first robotically assisted heart bypass performed in Germany in May 1998 and the first performed in the USA in September 1999, and the first all robotic assisted kidney transplant performed in January 2009. The Da Vinci was released in April 9, 2009 in the market and initially sold for US dollars 1.75 million. In 2005, a surgical technique was documented in canine and cadaveric models called the transoral robotic surgery, shortly TORS, for the Da Vinci robot surgical system, as it was the only FDA-approved robot to perform head and neck surgery. In 2006, three patients underwent resection of the tongue using this technique. The results were more clear visualization of the cranial nerves, lingual nerves, and lingual artery. The patients had a faster recovery to normal swallowing. In May 2006, the first artificial intelligence doctor-conducted unassisted robotic surgery was on a 34-year-old male to correct heart arrhythmia. The results were rated as better than an above-average human surgeon. The machine had a database of 10,000 similar operations and so, in the words of its designers, was more than qualified to operate on any patient. In August 2007, Dr. Sijo Parkatil of the Robotics Institute and Center for Urology, Winter Haven Hospital and University of Florida, USA, performed the first robotic-assisted microsurgery procedure, denervation of the spermatic cord for chronic testicular pain. In February 2008, Dr. Morgan S. Gudetti of the University of Chicago Commerce Children's Hospital performed the first robotic pediatric neurogenic bladder reconstruction. On 12th May 2008, the first image-guided MR compatible robotic neurosurgical procedure was performed at the University of Calgary by Dr. Garnet Sutherland using the neuro. In June 2008, the German Aerospace Center DLR presented a robotic system for minimally invasive surgery, the microsurgery. In September 2010, the Eindhoven University of Technology announced the development of the SOFI surgical system, the first surgical robot to employ force feedback. In September 2010, the first robotic operation of the femoral vasculature was performed at the University Medical Center Gianna by a team of Borat Gersak. Applications of robot-assisted surgery, ophthalmology, heart, also known as cardiac ailments, thoracic, thoracic gastrointestinal gynecology, bone, also known as orthopedics, spine and spine, transplant surgery, general surgery, urology, pediatrics. Major advances aided by surgical robots have been remote surgery, minimally invasive surgery, and unmanned surgery. Unmanned is one. Due to robotic use, the surgery is done with precision, miniaturizations, and smaller incisions, decreased blood loss, less pain, and quicker healing time. Articulation beyond normal manipulation and three-dimensional magnification help to result in improved ergonomics. Due to these techniques, there is a reduced duration of hospital stays, blood loss, transfusions, and use of pain medication. The existing open surgery technique has many flaws, such as limited access to the surgical area, long recovery time, long hours of operation, blood loss, surgical scars, and marks. The robot scars range from $1 million to $2.5 million for each unit, and while its disposable supply cost is normally $1,500 per procedure, the cost of the procedure is higher. Additional surgical training is needed. Operate the system. Numerous feasibility studies have been done to determine whether the purchases of such systems are worthwhile. As it stands, opinions differ dramatically. Surgeons report that although the manufacturer of such systems provides training on this new technology, the learning phase is intensive. One has to learn how to use these damn systems designed by a person that doesn't have any knowledge of surgery. Is intensive, and surgeons must perform 150 to 250 procedures to become adept in their use. During the training phase, minimally invasive operations can take up to twice as long as traditional surgery, leading to operating room tie-ups and surgical staff keeping patients under anesthesia for longer periods. Patient surveys indicate that they chose the procedure based on expectations of decreased morbidity, improved outcomes, reduced blood loss, and less pain. Higher expectations may explain higher rates of dissatisfaction and regret. Compared with other minimally invasive surgery approaches, robot-assisted surgery gives the surgeon better control over the surgical instruments and a better view of the surgical site. In addition, surgeons no longer have to stand through the surgery and do not get tired as quickly. Naturally occurring hand tremors are filtered out by the robot's computer software. Finally, the surgical robot can continuously be used by rotating surgery teams. Laparoscopic camera positioning is also significantly steadier with less inadvertent movements and robotic controls than compared to human assistance. There are some issues in regards to current robotic surgery usage in clinical applications. There is a lack of haptic in some robotic systems, touch, currently in clinical use, which means there is no force feedback or touch feedback. Surgeons are thus not able to feel the interaction of the instrument with the patient. Yeah, one should have a feeling, touch. Some systems have already have this haptic feedback. Haptic is the touch. Haptic feedback in order to improve the interaction between the surgeon and the tissue. The robots can also be very large, have instrumentation limitations, and there may be issues with the multi-quadrant surgery as current devices are solely used for single quadrant applications. Critics of the system, including the American Congress of Obstetricians and Gynecologists, say there is a steep learning curve for surgeons who adopt the use of the system, and that there is a lack of studies that indicate that long-term results are superior to results following traditional laparoscopic surgery. Complications related to robotic surgeries range from converting the surgery to open, pre-operation permanent injury, damaged viscera, and nerve damage. From 2000 to 2011, out of 75 hysterectomies done with robotic surgery, 34 had permanent injury. These are real facts data, and 49 had damage to the viscera. Prostatectomies were more prone to permanent injury, nerve damage, and visceral damage as well. Very minimal surgeries in a variety of specialties had to actually be converted to open or be reoperated. Open means manual. Or reoperated on, but most did suffer some kind of damage and or injury. For example, out of 7 coronary artery bypass grafting, one patient had to undergo reoperation. It is important that complications are captured, reported, and evaluated to ensure the medical community is better educated on the safety of this new technology. If something was to go wrong in a robot-assisted surgery, RAS, it is difficult to identify culpability, and the safety of the practice will influence how quickly and widespread these practices are used. There are also current methods of robotic surgery being marketed and advertised online. Removal of a cancerous prostate has been a very popular treatment through internet marketing. Internet marketing uh, of medical devices is more loosely regulated than pharmaceutical promotions. Many sites that claim many sites that claim the benefits of this type of procedure have failed to mention risks and also provided unsupported evidence. There is an issue with the government and medical societies' promotion a production of balanced educational material. In the US alone, many websites promotion robotic surgery fail to mention any risks associated with these types of procedures, and hospitals providing materials largely ignore risks, overestimate benefits, and are strongly influenced by the manufacturer. One of the main benefits during this pandemic COVID-19 era is social distancing is maintained even in surgery. Moreover, movements that are not physically possible by a human is possible with the robotic arm. Multiple what is it, ways of rotating are available. Risks of robotic surgery can be categorized into those directly related to the use of the robotic system. Yeah, freedom of movement. You can have so much of freedom in movements. Risks of robotic surgery can be categorized into those directly related to the use of the robotic system and the general risks of the operating procedure. According to a recent consensus statement, robotic telesurgery in which the surgeon may be located at some distance from the patient poses unique risks. For example, precise control of the robot depends on the quality of the data connection between the surgeon's console and the operating room robot. Issues pertaining to the quality and maintenance of such data connections may be beyond the control of the surgical team, but still represent a risk management challenge of which the organization must be mindful. All mechanical freedom of movement. Okay, all mechanical and electronic devices are subject to failure. Surgical robots are no exception. Current systems are designed with features intended to minimize the potential for harm to the patient. Such features include system redundancy, fault tolerance, just-in-time maintenance, and system alerting. Robotic surgery is a relatively new technology that requires advanced operator skill, not usually learned in residency. The benefits of performing robotic surgery when performed by a trained, competent, and certified provider include shorter recovery times, less blood loss, less chance of infection, and less scarring for the patient, as well as superior visualization and instrument range of motion for the provider. Organizations that invest in the equipment for robotic surgery should take actions to ensure that patients who decide on robotic surgery experience these benefits and are not harmed. Healthcare institutions that employ surgical robots in clinical practice should develop and follow credentialing guidelines, begin a focused and ongoing professional performance evaluation with the specific triggers and measures related to robotic surgery, ensure that staffs are competent, trained, and credentialed and privileged to perform robotic surgery, provide patient assessment to ensure that the planned procedure is appropriate for the patient, improve operation room Team communication. For robotic surgery, the OR, operation room team must communicate in different ways since the physician conducting the surgery is typically positioned at a console away from the operating table, and the OR team members cannot see what the physician sees at the console. Lack of communication. Standardized process in the OR, including the count process. The count process, yeah, synchronization. Count process should take into account ISO 9000. A lot of times it has happened. It has been noticed that so many unwanted foreign objects are found after they finish the surgery, like the scissors, surgical knives, cotton, sponges used. Okay, the count process should take into account sponges, needles, and other supplies used, such as bulbs. Includes a check of tools and tool tips to ensure that they are secure and not broken prior to ending the procedure. Monitoring robotic procedures to ascertain the number of URFOs discovered and the number of counts that are off. So anything is missing, and blood transfusions required. These are good indicators of the skill or lack of skill of the provider, service provider. Maintain robust quality review processes in which all cases are evaluated consistently and comprehensively to identify opportunities for improvement in patient safety for this new and evolving technology. The turn of the 21st century was witness to a significant technological milestone in American healthcare. The approval of the first robotic surgical system by the US Food and Drug Administration, short the FDA. Now, almost 2 decades later, robotic assisted surgery (RAS) is used for hundreds of thousands of procedures each year, and the number continues to grow. Unlike in traditional laparoscopic or open surgery, in which a surgeon uses his or her hands to operate the surgical instruments, RAS uses a computer-assisted robot as an intermediary in the surgical process. The surgeon sits at the console and uses hand and foot controls to maneuver the instruments, and a small camera and thin robotic arms through small incisions in the patient. So here about keyhole, pinhole, LASIK. The surgeon is able to monitor progress using a three-dimensional viewer on the console. During RAS, the surgeon typically is in the operating room but removed from the patient. However, the technology also offers the possibility of robotic telesurgery, in which the surgeon operates the robot from a remote location. Since its inception, RAS has been lauded as a symbol of medical progress and featured prominently in print and electronic media. Healthcare organizations of all sizes have invested in robotic surgical technology, and the number of types of procedures done using robots have expanded over the years, reaching various specialties such as general surgery, urology, gynecology, cardiology, otolaryngology, and orthopedics. With the time, more applications for robotic surgery will most certainly emerge. For example, in 2017, the robot performed dental implant surgery without direct human assistance, the first surgery of this kind. However, despite RA's growing popularity and proven and purported benefits such as greater precision and visualization, smaller scars, faster recovery, lower infection rates, and less pain, many questions have risen about patient safety. Long-term outcomes and the appropriate use of this technology. RAS potentially offers benefits for both patients and surgeons. However, like any medical technology, it also presents safety challenges. Examples of these challenges include ensuring appropriate training, overcoming learning curves, evaluating for proficiency, determining patient selection criteria, and providing appropriate informed consent. Yeah, that's a must. Informed consent for patients having robotic procedures. Since the time RAS was initially approved until present day, training has persistently been a top risk concern, in part because no universal consensus has been reached on the appropriate type and duration of training or credentialing standards. Although Some professional organizations have made recommendations, others are still working to define standards for the fairly new technology. For doctors whose primary surgical experience is using a robotic surgical system, conversion to open surgery might be problematic. In these cases, another surgeon who is experienced with open surgery should be available to assist if necessary. Surgeons and surgical team members must also be aware of the risks that can occur as a result of conversion, such as issues related to patient positioning and prolonged use of anesthesia, and have plans in place to manage those risks. In addition to comprehensive training for surgeons, healthcare organizations should consider essential training for other members of the surgical team, such as the anesthesiologist, assisting surgeon, and the nurses. Along with the training consideration, surgeons should be aware of the steep learning curve associated with using robotic surgical systems. Proficiency with these complex systems is a major factor affecting whether a robotic surgical system can be used safely. Safety is of utmost importance when it comes to dealing with lives. Surgeons must master the use of the surgical techniques for the procedure they plan to perform. Unfortunately, attaining proficiency with a robotic surgical type of system is not a one-size-fits-all formula. It should be customized. The number of procedures required to demonstrate proficiency varies based on the type of procedure, and no firm standards have been set. Further, various other factors also contribute to proficiency, such as basic skill, experience, and comfort level with technology, familiarity with the procedures being performed, frequency of cases, and type of training. Just as with other surgical techniques, robotic surgery skills are honed over time. Improve, refine. For less experienced surgeons, procedures might take longer, associated costs might be higher, and the risk of complications might be greater. Proctoring and mentoring opportunities established as part of each healthcare organization's credentialing guidelines can help contribute to patient safety initiatives and address risks related to learning curve and proficiency. Additionally, organizational policies should establish criteria for maintaining proficiency over time, such as performance monitoring, continuing education, training, and re-credentialing. One of the driving factors in the rise of robotic surgery is patient demand. However, some patients who are eager for this technology may not be ideal candidates due to comorbidities or other factors. To counter increasing patient pressure, a crucial strategy for managing robotic surgery risk is careful consideration of patient selection criteria. By developing greater awareness of potential risk factors and contraindications of our robotic surgery, healthcare organizations and surgeons can create and implement patient selection guidelines and assessment protocols, as well as reinforce or improve quality measures. Further, documenting the assessment of patient risks in accordance with established selection criteria supports the clinical decision-making process. Beyond establishing patient selection criteria, it is also crucial to manage patients' expectations related to RAS. This may prove challenging for surgeons because of the technology is complex, and direct claims about benefits and safety can be difficult to make. Compounding this challenge are aggressive marketing from the device manufacturers and idealistic hospital advertising that might overestimate benefits, overpromise results, and are failed to define specific risks, leading to inflated patient perceptions. Yeah, holistic view, 360 degrees view is essential. One has to look at all the sides. Don't just look at the positive side, right side, and forget the negatives or the dark side. There are always two sides, even in a coin. The result of these efforts might help drive the perception that robots make the best surgeons. That is not true. A careful review of advertising and marketing efforts promoting RAS might help healthcare organizations and medical staffs pinpoint potentially misleading statements and identify opportunities for clarity. Ultimately, these strategies might assist patients in making more educated and informed decisions about the care. Just like if any other type of surgery, informed consent for RAS should involve a process undertaken by the treating surgeon to educate the patient about his or her procedure. The informed consent process should include disclosure of standard consent information, example, and the explanation of the procedures. The healthcare providers who will be involved in the procedures, potential risks and benefits. Alternative options, etc., as well as information specific to RAs. Yeah, alternative options. Most of the people in the medical field do not provide alternate options, especially the surgeons. One should never go to the surgeon directly. Never consult with the surgeon for very menial issues, because they straight away recommend surgery because they can make a lot of money. Pre-surgery, conducting the surgery, then post-surgery, they mint. For example, surgeon should educate each patient about the procedure he or she is having, how it is performed. Surgery should be the last option, not the first option. If there are other options, better expedite those options. Okay. The potential risks of robotic surgery in relation to equipment failures and malfunctions such as system errors, video imaging problems, broken components, electrical arcing, sparking, and charring, unintended instrument movements, the potential risk of robotic surgery in relation to the patient's specific condition and comorbidities. So the surgeon's past experience with RAS in general and with the recommended robotic procedure, specifically alternative options or techniques for treatment, and any information about how these techniques compare to RAS. What will happen in the event of an emergency or complication? Example, the surgeon will switch to open surgery or traditional laparoscopic as well as any related risks. Taking the time to provide patients with these details and answer any questions can help ensure that they have the appropriate information to make informed decisions about the treatment. Following the informed consent process, surgeons should document these discussions in patients' health records and include copies of any related consent forms. Too much dependence on machines will certainly lead to disaster ultimately. Hence, a manual override system should be built in such that in case of a system failure, that's a must. System failure, the surgeons can resort to traditional manual procedure and ensure patient safety, what is called as open surgery. I really wonder when the RAS ends in catastrophic failure, who or what is to be blamed? Surgeons, surgical team members, hospital where the surgery was performed, the robot or system used, the company that supplied the RAS system, programmer who did not test the program with the real data, partner. Maybe God. I experienced these in any computerized system, whether it be banking, ticket reservation system, online orders, etc. Machines should be our slaves and not the vice versa. MI, ML, machine learning, AI, artificial intelligence, IoT, Internet of Things, and whatever crap expert systems here should be used with caution. Nothing is 100% foolproof or fail-safe. Risk is always built in or hereditary in nature, and one should never ignore it, especially when it comes to dealing with human lives. Apply failure effects and modes analysis, FEMA or FE, failure effects and criticality and mode analysis, FEMC, failure effects and modes criticality analysis. Contingency planning is a must. Contingency, alternate plans must be in place. Manual override is a must. Perfection is a practical impossibility. Take a holistic view. As I said, don't just look at one side and forget the rest. That is what these doctors, people in the medical profession do. Whether it be the device manufacturer, hospitals, system admins, they want to make money. That is their only intention. They don't care whether the patient recovers or dies. They'll say it is there is a possibility. Debates, discussion, and open-ended topics like this can go on forever. Anyway, let me pull the plug here. We'll meet again real soon with another interesting topic. Some of the statements, views expressed are solely mine based on limited knowledge gained over 6 decades of versatile experience. Always watch these videos with the closed captions, subtitles for absolute 100% comprehension as per my sincere recommendation zillion times so far. I know I rushed through to complete the presentation within 20 minutes maximum. This time limit is self-imposed to retain the viewer's attention as a norm. I am quite aware of the fact that I exceed this time limit. Sometimes I take double or even triple this time depending on the topic, since I make honest attempts to cover The selected topic more elaborately, including so many intricate fine details referring a wide variety of sources, in particular Wikipedia, quite extensively besides articles and books published recently. Besides, of course, I sprinkle my own salt and pepper and season it with my personal experiences so far in my life and also intuition. Stay at home as much as possible to maintain social distancing attributed to pandemic novel COVID-19 and prolong your lifespan. Lead a healthy life. God, also known as a superpower, is the one and only one who can put a stop to natural and unnaturally, maybe biowar and cyber war events like pandemics. Yeah, cyber war, that can happen. And it depends on the missions. Events like pandemics and epidemics will ultimately pave the way for apocalypse and extinction of all sentient species on Earth for no fault of others. Yeah, cyber war will be the future. Cyber war, bio war. Bio war has already happened. Cyber war is also happening. There won't be any real war. It will be like a video game. Rest in peace and harmony.